Welcome, everybody. I'm Dr. Melanie Béchard, Chair of Canadian Doctors for Medicare and a pediatric emergency room physician based in Ottawa. We are very excited that you are joining us tonight for this webinar about the future of public health care in Canada. Thank you so much for taking the time to be here with us. I know there are probably many demands on your time. For anyone who is new to Canadian Doctors for Medicare, we are a nationwide, evidence-based, and nonpartisan organization dedicated to preserving and strengthening Canada's publicly funded health system. We advocate for innovations that are evidence-based, improve access, and have quality, equity, and sustainability. On the topic of equity, we would like to recognize the significant and unjust health disparities that Indigenous people continue to face today due to systemic racism and the effects of colonization. We hope to work towards reducing these inequities as we continue to advocate for better Medicare. And we acknowledge that the CDM office is located on the traditional territory of the Wendat, Seneca, and Mississaugas of the Credit. If you are a medical student, resident, or physician and not yet a member of CDM, please consider joining today. You can stay engaged with us on topics that are important to Canada's public healthcare system, including virtual care and pharmacare. We'll add a link in the chat box to where you can easily become a member. We have a few great panelists here tonight that I have the distinct pleasure of introducing to you. First, we have Dr. Lucy Barker, who is a psychiatrist, clinical associate at Women's College Hospital, a research fellow at Women's College Hospital and the University of Toronto, and PhD student in clinical epidemiology and healthcare research at U of T. Her research interests include perinatal psychiatry, gender and mental health, and equity within mental health service design, delivery, and access. We also have Dr. Crystal Pinto. Dr. Pinto is a community psychiatrist in Toronto. She has a particular interest in collaborative models of psychiatric care and increasing access for marginalized groups. And we have Dr. Brandon Doucet, a practicing dentist in Nova Scotia with interests in oral surgery and public health. He's the founder of the Coalition for Dental Care, a group looking to highlight the shortcomings of our dental care system while advocating for a more humane alternative. In a moment, I'm going to turn things over to our panelists to talk to us a bit about mental health care and dental care and how they are or are not incorporated into our public health care system. We'll then move on to Q&A with questions that you, the audience, will provide. Throughout the discussion, you can post questions in the chat box, and we will put those questions to our panelists in the second half of the webinar. You will also have the ability, as Katie mentioned, to unmute if you would prefer to ask your question audibly. So without further ado, let's get started. At CDM, we wanted to take a small step back mid-pandemic to take a look at our public health system and acknowledge some of the gaps or cracks that have been exposed in the last 19 months. What more can we find out about communities that are currently underserved? Which services are not covered? And how can we strengthen our public healthcare system to better take care of one another? We hope to begin a conversation about how to renew our efforts to make Medicare better, both improving the care already covered and expanding what services are included. So to keep things informal and fun, I hope no one minds if we all use first names during this session, but Lucy and Crystal, when it comes to mental health services, could you paint us a bit of a picture of how those services are or are not currently covered under the public healthcare system?
So as mentioned, my name is Lucy and Dr. Crystal Pinto, and I will be presenting a little bit about the mental health system in Canada and really systems in Canada, because as you'll see from our talk, as I'm sure many of you are aware, there are a real array of the way that services are delivered currently. We have no conflicts of interest, and of course our views are shaped by our contacts, and we're both psychiatrists and we both work primarily in Toronto. So we'll be talking a little bit about the mental health burden, existing mental health services, and barriers to services. So just to kind of give a bit of a frame to start off with, this is the estimated kind of what's the burden of mental health in Canada. And this is looking, we have the kind of current or recent in 2011 in the darker green, and then there's a projection for the future in the lighter green. And what we can see here is that about 20% of Canadians experience a mental illness within a 12-month period. And so we have a high burden of mental illness, but which fits with what we see clinically and what I'm sure people are aware of in terms of their friends, family, themselves. It's also a big economic burden. So over 40 billion estimated in direct costs and over 6 billion estimated in indirect costs, and those are 2011 numbers. It's really hard to get a proper figure though, because mental health care is delivered in so many different areas by so many different people. And so these were the kind of best numbers that the Mental Health Commission of Canada could come up with.
So when we think about who is actually delivering mental health care, it's actually pretty much spread across the board. In terms of physician care, most people end up seeing their primary care provider. So in fact, I would argue that the bulk of the mental health that is being delivered by physicians is usually being delivered by people's primary care providers. And what that actually means is that there can be a huge gap in what kind of care people can access depending on people's comfort with providing mental health care. The next place people often access mental health care is actually in the emergency department. And so the first person they will see is the emergency room physician. From there, they may or may not get moved on to psychiatry, which can also be accessed through their primary care providers. So this can happen in all sorts of settings. This can happen in an inpatient setting, in an outpatient setting. It can happen within hospitals. It can happen through individual private practices. And you also see a lot of people actually accessing psychiatric services through the forensic system. The next group of people are actually physicians, usually not psychiatrists, who have trained specifically in psychotherapy. So these sort of core physician-provided services are usually the ones that are covered by most provincial health plans. Outside of this, you would have psychologists who would provide oftentimes private, but can also be affiliated with publicly funded systems, so within hospital departments or within community organizations. Similarly, social workers as well as licensed psychotherapists. The other big source of support are, of course, community resources, crisis lines, which can involve both the licensed professionals as well as peer support workers and other people with lived experience, as well as lots of informal networks. So we know that a lot of mental health care is actually provided by family and friends, as well as through religious and spiritual organizations.
And a lot of care is delivered in the public system. As Crystal mentioned, a lot of that is the physician-delivered care, and we also have care that's delivered in the private system. Even within the public system, care is really divided up and it's funded in many different settings, which means that there's kind of many different types of services that are spread across the system. For example, in Ontario alone, we have the Ministry of Health, but then also the Ministry of Children, Community and Social Services. Within long-term care, there's mental health care being delivered. Within the education system, post-secondary education. And so there's really a range of ways that that publicly funded mental health care is being funded and different kinds of systems that are taking place concurrently. There's also through the federal government separate funding system for the Intimate Federal Health Program. So there's really many different ways that it's being funded even within the public sphere. And then there's the private sphere. So there's people who are paying, who have private healthcare insurance, for example, that they pay for privately or through their workplace, out-of-pocket expenses, and then other types of systems. So community grants, donations, things like that. It's hard to get a really good sense of what proportion is delivered in the private system versus public system. But for example, the Canadian Psychological Association looked at psychologist services alone. Canadians spend approximately $950 million annually, and about 30% of that is estimated to be out of pocket. So it's a huge burden on individuals. In terms of need being met, so this is Statistics Canada data from 2018, and we can see here unmet need. And the unmet need, especially for counseling and therapy, is quite high, and only about 50% of people are having their needs fully met for counseling and therapy. And in terms of any, about 56% of people are having their needs fully met. So there's huge gaps here. In some of the work that I've done, so we look, I used the Ontario Health Administrative databases for a lot of my research. And so we're really limited to look at primarily physician data. And so for example, the study, we looked at people who visit an emergency department for a mental health reason in Ontario. And we found that about 60% of them did not receive any outpatient physician mental health care within 14 days of the ED visit. So these are people with high acuity illness, and they're not getting care. In my PhD, I focus specifically on postpartum psychiatric emergency department visits. And similarly, there's a huge burden of people who aren't getting care following those visits. And these are people who are showing up, they're demonstrating a need for mental health care, and they're showing up in a hospital and they're still not getting care. Even within the publicly funded system, access to care is not equitable. So this is looking at postpartum psychiatric emergency department visits and looking specifically at who had physician mental health care prior coming to the emergency department versus not. And we know that people living in rural communities, and we found that people in low neighborhood income quintiles were more likely to have their first presentation in the emerge, as opposed to be first accessing primary care or a psychiatrist. And that's demonstrating gaps in this population. And this is a population, a postpartum population, where people are highly connected to primary care and to healthcare in general. And this is within a publicly funded system. So there are serious gaps across the board. Mental health care is also underfunded, which presumably contributes to some of these gaps. So it's about 7.3% of Canada's healthcare budget, and this is below other G8 countries. I think I've seen about 13% estimate for the UK, for example. Within provinces, so across provinces, care is unequally distributed, and then even within provinces. So this is looking at the supply of psychiatrists across Ontario, and this is work done by my colleague. And we can see here that, Crystal and I both work in Toronto. We can tell you that it's really hard to get in to see a psychiatrist. There are long wait times, and we're in a highly densely populated region of psychiatrists in terms of the number of psychiatrists per person. And even here, there are a lot of gaps and often high wait times for people to get the care that they need.
So then, of course, we want to think about what are the barriers to care. And the first thing, of course, is what Lucy talked about. It's whether or not the services are available, so whether there are services that match patients' needs. And one of the big problems you see is, of course, whether or not anyone's accepting new patients. The second piece, of course, is whether it's culturally safe and relevant. We know that marginalized populations actually have a much harder time accessing care, especially psychotherapeutic care. And then, of course, a major barrier for that is language, because it's really hard to provide psychotherapy with the use of a translator, because it makes the bond much more difficult. The other big problem is, of course, financial. So especially because so much of therapy as well as medications aren't actually covered, that is the first barrier. And then the next one is just being able to access care. So being able, before virtual care, being able to access transportation, childcare, taking time off work. But even with virtual care, whether or not people have access to technology, like do people have cameras or systems that work that way? Even just trying to navigate the system is quite difficult. So what we know is that in order to figure out where you're going to be able to get help, you have to be willing to likely look up services yourself, being able to navigate a very complicated system, which is incredibly fragmented, try to figure out who's accepting patients, when they're accepting patients, how they're seeing people. And all of this takes time and effort, which again is a constraint if you need to work for a living. We know that discrimination and stigma are part of it as well. And then, of course, there are the other ones that are less tangible, like whether or not the services you're looking for are funded by OHIP, whether they are research services. So we know that services like transmagnetic stimulation, which can be very useful for treatment-resistant depression, is only available often in academic settings or through quite expensive private pay systems. Similarly, while the newspapers are flooded with stories about ketamine and psilocybin use, being able to access that is going to be quite difficult as well. And so there are lots of different ways in which people's ability to access services is actually quite inequitable.
Yeah, So those are all the slides that we have, but of course, we'll spend most of the time in terms of discussion. Thank you.
Amazing. Thank you so much, Lucy and Crystal. We will save questions for the end, but there is one quick point of clarification. IFH, I took that to mean the interim federal health plan for refugee claimants and asylum seekers, correct?
Yes.
Yes. Okay, wonderful. Brandon, could you please give us a sense of how dental care works right now in Canada? What is and what isn't covered in most cases in the public system? And what are groups like the Coalition for Dental Care pushing for?
Sure. So when we look at dental care in Canada, we really, I can say in the simplest terms, dental care is not included in our universal healthcare system. And when I say that, I mean the overwhelming majority of spending on dental care is private. So this would be, through work-related insurance, out-of-pocket payments, and that accounts for the overwhelming majority of spending at about 95%. And only a meager 5% of dental spending comes from targeted government programs. So these can help various targeted populations, whether that be Indigenous peoples, children, but in reality, a lot of the times it's low-income children, people on social assistance. And as you can see, 5% of dental spending is so low that oftentimes the fees those programs pay out are much below what private plans would pay. So we end up struggling to, people on those plans struggle finding a dentist who will accept them. And oftentimes those programs, they won't cover preventative services like cleanings, and they favor extractions rather than saving teeth. So there's major problems even within the existing targeted programs. And just to give comparison to some other countries, I know Canadians like to be smug about having universal health care with respect to the Americans, but when it comes to dental care, public dental spending accounts for about 10% of dental spending in the US, whereas we're only 5%. And say if you look at a place like Japan, about 75% of dental spending is public. So, dental care is basically more or less included within their universal healthcare system, other than, cosmetics and stuff. So, and because we have such a privatized system, what we see is there's large inequities in what people are able to access with respect to dental care. So just to put some numbers to this, there's about 1 in 3 Canadians who lack any dental insurance, and over 1 in 5 who avoid the dentist each year because of financial constraints. Putting this in context as well of, we see a trend within, like if we look at the nature of the economy, we're actually seeing access to dental care getting worse. So we're seeing a lot of elderly people retiring and losing their work-related benefits. And we're also seeing a lot of younger people working in the precarious gig economy, which doesn't provide benefits like dental insurance tied to their labor. So we're seeing more people lack access to dental care. And this is all, before the COVID-19 pandemic, which, as I'm sure many of you are aware, has caused great financial harm to a lot of people. So a lot of people are becoming unemployed and losing those work-related benefits, and they're also losing disposable income to pay for these services out of pocket. So there's a lot of people who are lacking access to dental care or struggling to scrounge up enough change to make the co-payments with their insurance. And so people are suffering. And there's a lot of consequences to this as well that can extend beyond the mouth, as I'm sure many physicians here are aware of. So just to talk about some of the relationships between poor oral health and overall health. So poor oral health has been associated with a lot of conditions like cardiovascular disease, diabetes, having a low birth weight infant, aspiration pneumonia, osteoporosis, metabolic syndrome, stroke. I'm sure there's many others, but those are just some off the top of my head. When we're looking at the relationship between oral health and overall health as well, we need to understand the social context of overall health as well. So you can imagine how difficult it is to find a good paying job if you have visible decay on your front teeth or you're missing front teeth. It affects your employability, which means you're more likely to be in poverty, which means it's going to be even harder to find dental care. And people get stuck in this cycle, and it's really hard to break out of that cycle of poverty. And this is something that a lot of people end up neglecting dental care. They neglect preventative services, and really the only time they go in to see the dentist is when they're experiencing pain. And it's something that when people are unable to go to the dentist and they only come in pain, they have to seek treatment wherever they can. So I've seen countless times people come in trying to extract their own teeth, and I kind of have to try to dig out whatever's left, which is, you know, a horrible thing to see, but it's surprisingly common as a dentist who has interest in surgery to see people who are that desperate. But there's also a lot of people who end up in emergency departments seeking treatment for dental pain, a place that, you know, I'm sure the emergency physicians want to help them out the best they can, but, you know, they're not equipped to do root canals or to extract teeth. And the main reason people end up in the emergency department is because a cavity in the tooth gets so large that it hits the nerve in the tooth and causes a toothache and what's called a dental abscess, where pus infects the bone underneath and causes a swelling in the face. And oftentimes these people who went to the emergency department because they couldn't afford dental care in the first place, basically they're usually given, you know, a prescription for pain medication, which often comes in the form of, you know, some form of opiates and an antibiotic, and told to go see a dentist. So, you know, these people ended up in the emergency department in the first place because they couldn't afford to see a dentist. So oftentimes they end up returning back at a later time when it flares back up again. And, you know, we know the problems of relying on opiates when we're not addressing the root cause of the pain. We know using these antibiotics increases the likelihood of drug-resistant strains developing. And there's also just the added cost to our healthcare system when we look at people, you know, it's about 1% of ER visits are for non-traumatic dental injuries. And it's estimated that this costs about $150 million per year. In reality, that's probably an underestimate, considering, you know, some of these people need to be hospitalized because the infections get so bad. You know, dental infections, it's not common, but I mean, people can die from dental infections. An infection of an upper tooth can spread to the brain. An infection of the lower tooth can cause swelling that compresses on the airway. So, you know, leaving these infections linger can cause some really serious concerns for people, as well as just affecting one's quality of life. So we see it as something that trying to provide everyone with access to dental care is really, you know, we want to give people a fighting chance at living a dignified quality of life. And the existing system we have, it doesn't just, you know, it's not the odd person falling through the cracks. It's actually large segments of the population that can't afford routine dental care. And for people who, you know, there's a lot of people who just completely lack access to dental care, but there's also a lot of people who struggle accessing dental care and who are underinsured and, you know, struggle to make the co-payments with things. So what we at the Coalition for Dental Care, so that's the group that I founded to help raise awareness for this issue and also, you know, advocate for a more humane alternative. What we want to do, you know, in the simplest term, we see including dental care within our universal healthcare system as being a great first step. Because if we provided everyone with dental insurance, we wouldn't see people neglect dental care for years of their life when, you know, maybe their job doesn't provide those benefits, maybe they're unemployed, they're retired, whatever it might be. If people didn't have to neglect that care in that time, we'd see a population with better oral health. People wouldn't let problems get to the point. I see people all the time who know they have a lot of work that needs to be done, but they, you know, they just want to get out of pain, and we'll probably see them in another year or so to deal with another problem. And it's something that having everyone buy into the same system is much better, politically speaking, than the existing targeted approach for funding dental care. Because what happens is, the targeted programs are easy to undermine politically, because within society, people see these programs as, you know, people getting free stuff, whether we like it or not. That is kind of the political reality. And these programs are like, they're de-indexed from inflation, so we don't see fees go up each year. So dentists are more reluctant to take on these patients because oftentimes the programs pay less than half of what a private plan pays. So what we see is that, dentists won't accept people who even are lucky enough to have this sort of coverage, let alone the over 1 in 3 people who lack dental insurance. Whereas universal programs, there's much greater buy-in from society as a whole. So if they try to cut these programs, politicians try to cut these programs, there's much broader backlash from society as a whole, and they stand the test of time far better than we see the targeted programs that we have with dental care. But we also think that we can improve on the existing, public funding of private clinics models, because having dental insurance doesn't mean you have access to a dental provider. Same thing as, having medical insurance doesn't mean you have a family physician. So what we want to do with dental care is also have a strong, robust sector of publicly owned dental clinic to help serve the populations that currently lack access to dental care. So having dental clinics in schools, long-term care facilities, prisons, community and Indigenous health centers. And it's something that this would be a very effective way to provide cost-effective dental care to the population, because what you can have in these publicly owned dental clinic is what are known as dental therapists. Now, these are mid-level dental providers that can do, simple procedures like cleanings, fillings, simple extractions, all at a fraction of the cost of a dentist. And this would allow us to greatly increase the dental workforce. There's numerous studies that show they do just as good of work as dentists. They're used in over 50 countries across the world, New Zealand being a very prominent one. They have a school-based dental program I think this year is their 100th anniversary of that program with a dental therapist working in them. It's highly successful system. We actually had a system like that in Saskatchewan in the 1970s and 80s, where dental therapists worked in these easily accessible school-based clinics, and it was highly successful. Over the first 10 years of the program, the need for fillings and extractions in children went down by half because it was very easily accessible. Preventative services were able to get to the people that they needed it to, whereas with private practice, even when people have coverage, for one, a lot of dentists don't accept them, but for two, also a lot of people have a hard time taking time off of work. For my first 2 years after graduating, I worked in Newfoundland, and I had to have a lot of patients who would drive 2.5 hours to see me. That's not feasible for a lot of people. So having the dental care actually, bringing the dental providers to the people in schools and long-term care settings, in rural and Indigenous health centers, prisons, stuff like that, it's a much more effective way to make sure people don't just have coverage, but actually have access to care. So as I was saying, with the Saskatchewan plan, the need for fillings and extractions went down by half within the first 10 years of the program. And it's something that if you apply this across society as a whole, you can imagine how much better we can do when it comes to bettering the oral health of the population, as well as this dental therapy model is very cost effective. So once we start breaking dentists' monopoly on care, and we can answer the question, why does a filling have to cost $200? Maybe a dental therapist is willing to do it for $100. And we could also look at not having people work on a fee-for-service model, but having people work based on a salary. And when we have people work on a salary, they're not rushing to get to the next patient. They're happy to take the time needed to help treat, say, an autistic child who needs some extra time to be able to get the work done with them, or taking the time to teach people how to properly take care of their teeth and nutrition. Whereas with the fee-for-service model, people are just trying to get to their next patient so they can make more money. So really what we see with a universal dental care system is trying to include dental care within our universal healthcare system, but also improving on the existing system as is. Now, we see that this as an ambitious goal and something to work towards. We understand that that's, oftentimes these things are done in steps. So I am happy to see parties like the federal NDP proposing a plan to provide dental insurance to families making less than $70,000 per year. In the group between $70,000 and $90,000 per year, insurance with co-payments. So, you know, this isn't the universal system we're looking for. There's still going to be problems as far as struggling to find a dentist who will accept them and stuff like that. But it would be a big step in the right direction. And hopefully, if it were implemented, a step towards something even better. If we were to have that in place, it would bring Canada's public dental spending from about 5% of overall dental spending to about 15%. So, you know, that would be the single biggest investment in oral health in Canadian history. You know, in my mind, we still need to do more, but at least that's a step in the right direction. Thank you.
Thank you so much, Brandon. Before we start taking questions from the audience, and I'm sure you're all eager, if you're like me, you've been jotting down notes and questions all the way throughout, I did want to ask all three of our panelists about advocacy work currently underway to improve coverage of mental health and dental care services. Are there existing campaigns or efforts to expand coverage, and what work needs to be done to push for more change?
As I mentioned, that I'm the founder of a group called Coalition for Dental Care. So we're trying to help raise awareness for the shortcomings of our existing dental care system, as well as advocating for a better alternative. So we're taking on, you know, various things, whether it be writing op-eds, speaking at events like this, giving presentations to classes that are interested within the dental community, as well as just trying to reach out to the public through various initiatives, social media. And we actually just went through the process of writing a book. We've just submitted that to the publishers of Fernwood Publishing over here on the East Coast. And we're hoping to get started on a documentary film soon. So yeah, we're really trying to expand and take on as many projects as our capacity as a group allows. I'm very lucky to have a team that I'm working with that, you know, has a lot of different skills that I don't. So yeah, it's very helpful in that sense.
Thank you. From a mental health standpoint, I think, you know, there's a number of different initiatives underway. And as I mentioned, there's so many different, or as we talked about, there are so many different types of mental health providers. There are so many different kinds of systems in which it's working that I'd say the kind of initiatives there's also many different initiatives. So for example, like on a federal level, the Canadian Mental Health Association is quite active. And then federal bodies representing different mental health care providers. So for example, the Canadian Psychological Association, I believe is doing some advocacy in this realm as well. And then I think also kind of, there are also a lot of advocacy initiatives focused on specific patient populations. And so whether that be specific language groups, specific kind of life stages groups. So there's advocacy around child mental health. And then there's these kinds of different initiatives that are being piloted. I'm most familiar with the ones in Ontario in terms of increasing access to publicly funded psychotherapy that are being rolled out by the government. Some of them seem to be done in partnerships with kind of private companies. Some of them seem to be many different things popping up all the time. And one of the, I think, to me, one of the problems with, as we talked about, system navigation. So there's all these, even amongst the advocacy things and the new developments that are happening in terms of access, it's still very kind of separate, and you make different referrals to all the different services, and you have to really kind of be on your toes. So there's these different advocacy initiatives underway and different new programs underway. But I would say that there's a lot of different things going on. But for example, the Canadian Mental Health Association, because it's national, that would be kind of a group that's doing that work on a more kind of widespread level. Crystal may have some other.
Yeah, I think that with COVID, there's been a lot of sort of emphasis on just how fragile mental health can be, and also how difficult it is to access services within the Canadian system. And to sort of go back to Lucy's point, I think that there are so many different pieces, like there's so many different ways of understanding mental health that the system is quite fragmented. And like Lucy mentioned, because of this fragmentation, there's also these partnerships that are developing that aren't exactly transparent. So there's within Alberta and Ontario, there's sort of the government funded online psychotherapy, which is great. I recommend it to people all the time, but these were made with partnerships with publicly traded companies, right? So I've also had patients who very reasonably will tell me, well, I don't want to give all my personal health information to a publicly traded company. And it's a very legitimate concern. And so there isn't this sort of move towards creating a sustainable public system, but there is, again, that sort of sense of fragmenting this out and downloading a lot of responsibility to community partners, which allows people to access services, but doesn't sort of create that central place where everyone could access it all together.
And exactly. And there's providers are in so many different silos. So there's kind of physicians, and with physicians, there's the different specialties. And then there's the social work groups, psychological groups, and there's not always there's, people are very much working in silos a lot of the time. And I know there are definitely efforts underway, and there are lots of people doing collaborative work. However, there are kind of so many different interests at the table that it's hard to, I think there's often these barriers to how does everything come together, and there's lots of different viewpoints about what the best system going forward would look like.
I'm sorry, I'll add one last piece about it. It's that I think because of the focus on mental health right now, there's also a push towards trying to find the new and I think there's a lot of push towards funding of newer therapies or moving towards funding of those things, as opposed to some of the other pieces that we know are actually much more useful for mental health on a broader scale, especially for marginalized populations. So there's more attention paid towards psychotherapy, which is incredibly useful, and less towards sort of social supports, which might be absolutely vital as well for patients who are not.
Amazing. Thank you so much, everyone, for a wonderful discussion. As a pleasant rarity, we are right on time, and we have about 20 minutes left for questions and feedback from the audience. So I see that Nadia has their hand raised. Nadia will unmute themselves and voice their question. And I also see that Thara has placed a question in the chat. So afterwards, Thara will ask their question, and I'll do my best to monitor both. Thank you so much. Please go ahead, Nadia.
I want to ask Brandon, the dentist, when you talk to governments, knowing that a civilized society is one that caters to its most vulnerable citizens, what do they say?
So from my experience, I've done some work with the federal NDP through the health critic Don Davies and Jack Harris, who is a former MP in Newfoundland. And, they've been very sympathetic to the cause. I think they're a little more pragmatic in their plan is being viewed as a stepping stone towards it fully integrating dental care within our universal healthcare system. As far as speaking with other politicians and people who have positions of power, even people I know within the dental public health community, I get a sense of being overly pragmatic and thinking that bold things aren't possible. And what I have to try to stress to them, and there's not enough time in the day really to do that for them, but is that, all of the great things that we have within our society was once viewed as unreasonable and unattainable.
Mm-hmm.
And what we're see with that pragmatism is it's really it's setting this far, no further, when in reality, if we dream big and actually, put in the work to try to change things, there's no reason that dental care can't look very differently than it does now in a generation from now. So it's something that I really try to drill that into people's head as much as possible. But in my mind, from the political standpoint, that pragmatism just ends up serving a lot of big business interests, whether that be private health insurance companies who make a lot of money under the current system, whether that be there's an increase towards corporatization in dental care, so corporate-owned dental clinics, and just even dentists in general. It's dentistry's big business, and it's something that when even if you're well-intentioned, being more pragmatic ends up resulting in those business interests not being really confronted and just making minor tweaks around the edges. And what I try to stress to them is, we need to confront those problems. So
we have a question from Thara and then from Janet in the chat. First from Thara. I suppose this is probably for Brandon. What do you think is the appetite among Canadian dentists in general to participate in a system like the one you describe? I imagine that many people currently working in the private dental sector would be reluctant to transition into such a system. And what do you think could be done to make that idea more enticing to the average dentist? I know you touched upon some of this, but if you would like to expand on any points, please do.
Sure. So let me talk about this from a couple facets, because for one, I do know plenty of people within the dental community who would be interested in working in a system like this. And to be honest, I think it's more now than probably it was in previous generations. The problem is that those positions don't exist for people to work in. Now, with the broader dental community as a whole, I do think that there would be a lot of reluctance because of how meager the existing targeted dental programs are. What they worry would be that, those very low fees that are paid out for fillings for people in targeted programs is what they're going to get paid for everyone. And what really needs to be stressed and try to, hammer home to these people is that that's the nature of targeted programs. When it's kind of a you versus, they get free stuff, we have to pay for ours. There's this dynamic where, politically speaking, those programs don't stand the test of time well, and they're really easy to underfund, whereas universal programs have that broad buy-in from society as a whole. So they're able to, stand the test of time and be much more robust in that sense. But, let's be frank about it. Back in the day, doctors were the biggest opponents to Medicare. So I have I think dentists would probably by and large be the same thing. I'm sure there's going to be a few like-minded people as myself who would, be on the right side of this. But there's going to be a lot of moneyed interests that want to keep things the same because they benefit from the existing system. And the way I view it as is that, I'm sure dentists could be very well off under a universal dental care system, but, they're not going to give up. They're not going to give up that power they have over the existing system without a fight. So, we need to try to break free from their control and even look at, say, dental therapy. Dental therapy, the mid-level providers that I mentioned, is very much looking to break dentist monopoly on care. If they don't want to come to the negotiating table to, negotiate fair fees for a universal program, okay, we can train more dental therapists and try to fill that gap in other ways. Sooner or later, they're going to come to the table.
Thank you so much, Brandon. I should turn attention to the chat. There's some really wonderful comments from some of our participants in there. I also put a link to a timeline of history of Medicare in Canada, which does outline some of the intense opposition from Canadian physicians, including strikes, to the rollout of Medicare, and also a link to the Canadian Doctors for Medicare position statement on dental care for those who are interested. So our next question is from Janet. This one is for Lucy and Crystal. Most of the newest solutions for mental health supports focus on the medical model and are steering away from the root cause of distress, anxiety, and depression: poverty, debt, toxic work, or home environment. Do you know of anyone working from an anti-oppression perspective or from a social model?
I might be being a little bit optimistic, but I actually think that though there is a lot of focus on sort of the medical model, and we certainly work within the medical model, I think even within medical training and psychiatry training, there is a focus on a lot of the social determinants of mental illness. And I know that the CMHA across the country really does draw attention to that, to the ways in which poverty and social exclusion and stigma actually contribute to a lack of mental health. Having said all of that, again, to go back to the idea of sort of what gets everyone's attention from a government perspective is things like medications or the newest biological interventions, because in a certain way, they're actually easier fixes, right? Because you don't actually have to address all of the problems that would basically call for a rearranging of social structures. So that's where most of the attention goes, because it's easier to put our attention there. But I'd like to believe that a lot of advocacy in Canada right now, especially from the big mental health organizations, does in fact pay attention to some of the social determinants.
I agree with Crystal, and in a lot of the the evidence on housing first, and and the impact on mental health. And I think that is, it's within a lot of these plans, embedded within a lot of that advocacy work, and ensuring that that access to services is not, it's not kind of one or the other, but hopefully a both and approach. And so if someone doesn't have housing, is in a really precarious situation, only adding in psychotherapy is not going to be enough, but adding in housing, adding in all the different pieces that are needed. And so it really is, I think, it's broad reaching, and there are many groups that are doing advocacy work around kind of social determinants of health broadly and also individually. And so, I think it's all kind of an all-together type approach. And I agree with Crystal that most of the advocacy work that's underway, and within training models and within kind of delivery models, I think there is an increased awareness of these social factors that are contributing to mental health problems.
Thank you so much to you both. And it's such a good comment as well, even for non-mental health problems, even for dental care. If we ignore the social determinants of health, we really are rearranging deck chairs on the Titanic. Making sure that we have healthy social policies from the ground up is absolutely essential. If we focus just on the acute treatment aspect, we really are missing the biggest bang for our buck. So we have a question from Jerol and then from Susan. So from Jerol, if the dental care program in Saskatchewan was so successful, why was it discontinued? For Brandon.
Oh, yes, that's a very good question. Simply put, dentists didn't want the program. So the program was initially implemented in Saskatchewan in the early 1970s from NDP government under Alan Blakeney. And the program ran for 12 or 14 years or so. Very successful program. At its height, it was serving about 90% of school-age children. And basically a conservative government came to power, and there was kind of a combination of things that happened at the time. First, dentists were lobbying, basically saying, like, we can do the same thing, but with dentists being the center of it. So more of a private practice targeted program model rather than the publicly owned dental therapy model. And it was at a time when the government was trying to cut funding for social programs because it came out that they were running a higher deficit than they originally claimed. And they claimed that this alternative program would actually be less expensive. And the reality was that the conservatives listened to the dentists. Just to add a layer to this, basically about 400 dental staff, so a lot of them dental therapists, but also assistants and stuff like that in the Saskatchewan dental plan, who were basically all women, ended up getting fired without any notice because of the male-dominated dentists basically lobbied the conservatives, telling them like a bunch of lies about the efficacy of the dental program and the quality of work from dental therapists, which was not substantiated. They privatized the program so that it ended up being a dentist centered in private practice. And what we saw is it actually wasn't cheaper. Fewer people were using it. And even with fewer people using it, it wasn't cheaper. It made no sense. And it was something that the quality, like the oral health of children in Saskatchewan, you could see decline in the statistics of like things getting worse as this happened. So, it was basically, to answer your question, it's greed. Also, one more point to add is just that since then, there's been very few positions for dental therapists in Canada. In 2009, the Harper Conservatives actually closed the last dental therapy training program in the country. So one of the things we're trying to do with the Coalition for Dental Care is have a new dental therapy training program reopen, and then actually have community clinics for these people to be hired in. So one of the ways we're looking at the dental therapy model now is, do we have it be its own standalone thing? Or do we look at having, say, dental hygienists have the option of upgrading their, upgrading their skills and taking on some added roles if they want to take on the training for it? I think there's 10,000 dental hygienists in Canada. That's a big pool of knowledge who already know a lot on this, where we could expand the dental therapy workforce for this dual trained model very quickly. That's actually a model they use in New Zealand now too.
Thank you, Brandon. So we do have what I think will probably be our final question from Susan. I see that Laura has also submitted a question. If anybody else does have burning questions, please do place them in the chat and we'll do our best to follow up with answers after the webinar. But I think Susan's really sums up the theme of our entire Better Medicare thoughts and ideals here at Canadian Doctors for Medicare. So Susan is asking the group, I wonder if an umbrella approach to relook at what basic ideal healthcare looks like in Canada today, which would have to examine what should be included and how it can be accessed. Why is dental care and mental health care only available under our Medicare system in such a fragmented way in the first place? It requires a basic back to square one, she thinks, or they think. So how did we end up here? Brandon, Lucy, and Crystal.
With respect to dental care, it's really just kind of a historical anomaly. At the time universal healthcare was being promoted, there was very much a fight with physicians, and there was this view that's kind of, let's try to tackle physician services now, and we'll come back for things like dental care, prescription drugs at a later date. What we found, particularly with respect to dental care, is we've never really come back to expand Medicare, for anything. But with respect to dental care, some of the things that made it less likely was we also saw the rise of community water fluoridation at this time. So this is a very good way to help lower cavities within the population, low levels of fluoride within water. For every $1 spent on this, there's $25 in reduced dental decay needing to be treated. So we were seeing like society-wide less decay. We were also seeing, strong unionization within the country, resulting in people getting benefits like dental insurance tied to their work. And at the time, there were just so few dentists. So kind of the amalgamation of all these things just kind of, made it so that it didn't seem quite as urgent to do that at that time. I mean, it still was very important. It just never kind of reached the threshold needed to overcome that barrier.
It's a great question. I think for mental health, I think there's probably several different reasons. One thing that jumps to mind is kind of views on mental health that have evolved over the years and what's related to kind of stigma around mental illness. Approaches to mental illness have really shifted dramatically over the past century, decades, even few years. And we think about like asylums, thinking about different very different approaches to what mental illness is and how we treat it. And so our current view of mental health, and I think more and more people recognizing the importance of it, recognizing the fundamental importance of mental health as part of health overall. For many people is more recent, and I think that's kind of reflected in our policies, and we're in this kind of catch-up kind of phase where the policies that we have and the systems that we have don't really match what the reality is and what people's lived experience is with respect to their mental health. And so I think there's probably a lot of reasons. I think that those kind of societal shifts are probably contributory.
I think the other piece I would say is to draw a comparison between the discussion around sort of like the way in which dental services are provided. The other push was, of course, to understand mental illness as a purely sort of biological thing, divorced from psychology and divorced from social determinants of health. And so then that becomes a provenance of physicians, and physicians kind of treat everything. And there has been resistance within a lot of physicians to sort of like have psychotherapy services provided by non-physicians also be funded by the publicly funded system. So I think that there has been this other piece as well of sort of trying to keep everything again, that same partially grief, partially this sense of reimagining what mental illness is. And I think that there was this real hope that by somehow like reducing mental health or mental illness to a biological problem, that we'd come up with a solution that wasn't as complex as we've realized it needs to be. And so I think that that's part of what we're seeing as well, is that we've actually realized that we reduced the services to something that's not actually going to provide the full breadth of treatment that's needed.
Amazing. I think this is a great note to end on. I want to be very respectful for everyone's time. Thank you so much to our panelists. I hope we can give a virtual applause from across Canada or even across the world if we have anyone calling in internationally. And thank you so much to all of you for spending your time and learning. I was furiously taking notes. We will make this available as a video on our Canadian Doctors for Medicare YouTube channel. And I think we do also post to our website and social media as well, so you can catch up. Again, I think we had 1 or 2 unanswered questions, so we'll do our best to follow up with the panelists and distribute those answers. On the theme of better Medicare and a greater umbrella approach to healthcare, we did want to also have representatives from physiotherapy and from home care and long-term care, but we thought that cramming too much into a single webinar would do injustice to any one of the topics. So we hope that you've enjoyed 2 areas that we thought were particularly dire and that we were able to recruit really excellent speakers for. So thank you so much, everyone. If you do have any final questions or comments, please do listen to the chat. It has been such a pleasure, and have a lovely evening.